Hi everyone. Welcome everyone to the webinar sessions with Natural Remedies. So a very warm welcome to all the veterinarians for joining this webinar from the different parts of the globe. And we have participants from almost 14 different countries for this webinar also. And this webinar is presented by Natural Remedies Private Limited. I, Dr. Prakash Kangal, Product Manager at Pet Natural Remedies, will be the moderating person for today's session of this webinar. So to make this webinar very interactive, there are certain options available for chat, questions, and polls on your screen. So if you are using a desktop or a laptop, you can see these options on the right side of your screen. If you are using a mobile, you can see this option at the bottom of your screen. You can scroll up. So if you want to introduce yourself, please give any suggestions. If you are interested in, you can use the chat options. And if you want to ask any question, then please use the question options on the screen. You can ask your questions anytime during the webinar, and we'll be very happy to answer all the questions in the webinar at the end of the sessions. So after all these instructions, I would like to request Mr. Ayush Agarwal, our business head of Pet Natural Remedies, to introduce about Natural Remedies to all the participants. Over to you, Ayush. Ayush? He got freeze. Since there's a connection issue, sir, I'll ask PPAK Secretary Nagesh Reddy, sir, to please introduce about PPAK, sir.
Good evening, all. I welcome Dr. Narendra, our President, PPAK, and I myself, Secretary of PPAK. I welcome all the members of PPAK and Natural Remedies. As we promised, we along with Natural Remedies are conducting 4 webinars. Out of 2 already have been happened. So this is the 3rd webinar. So I came to know that there are members from all over India and from other countries also. So we had a webinar from Dr. Barnidharan, from Dr. Etiraj last week. And next week we'll be having a session from Dr. Umesh. And today's speaker will be introduced by our Dr. Parmeshwar. So Dr. Parmeshwar, please take over.
Good afternoon, everybody. I'm so excited and so happy to be with you all for the 3rd time. Successfully, we are conducting this kind of webinars during this lockdown time. We are all very lucky enough because when we look at the number of participants day by day, it's increased. It's becoming more and more popular. And all this credit goes to our friend, leader, and most innovative Dr. Narendra and beloved secretary and all other patron and other office bearers. I am very happy once again by thanking everyone who is participating today and joining for this webinar. I am here to introduce another great personality, Dr. Surya Das. The name itself sounds so good. Dr. Surya Das is becoming more and more popular day by day across the country and of course in few countries also now. Especially very much familiar and has got a depth of knowledge in anesthesiology, particularly small animal anesthesiology. He is here to tell a lot about small animal anesthesiology with all of your cooperation. And Dr. Surya Das was graduated during 1992 from Manuti, Thrissur Veterinary College, and also he is a postgraduate in veterinary surgery and radiology. He completed his postgraduation during 2000 year, and of course he is a PhD in ophthalmology. He has worked on ophthalmology, small animal ophthalmology. He has completed his doctorate in 2010. Surprisingly, his work was so appreciable in phacoemulsification because it becomes a very important part of small animal practice as far as ophthalmology is concerned, because many of the doctors still left with cataract surgeries. We are not able to do any justice to the dogs coming down with cataract, especially after 8-10 years. And work is on phacoemulsification and also trabeculectomy, which can be made use for the many veterinarians Indians who are into small animal practice, particularly like. And he has also guided many MBSc candidates, and he is also teaching this postgraduate diploma students in veterinary anesthesiology. Many also did this postgraduate diploma in veterinary anesthesiology, a distant kind of education from Tanwas. And in the beginning, after completion of his PhD, he was with Pukod Veterinary College. Am I right, sir?
So
Later, he joined as assistant professor in Tanwas. Now he is assistant professor in Tanwas with Department of Anaesthesiology. And he was appreciated and got many awards from Indian Society for Veterinary Surgery. And incidentally, he was called to establish a specialty veterinary hospital and lead and guide the anesthesiology aspects and ophthalmology setup by Republic of Seychelles recently in 2018. And more than during this outbreak, during this COVID lockdown time also, he has got a exciting story to tell you about. I request Dr. Suryadas only to tell this experience he had with one 800 grams small cookie for a open thorax surgery, I believe. Before that, I thank everyone for having joined this webinar today. And kindly I request Suryadas to share a moment about this 800 gram puppy open heart surgery for correcting this vascular ring anatomy, I believe, anomaly. Thank you very much.
Thank you, sir. Suryadas, sir.
yes, thank you for the nice introduction, nice words. So as he requested, let me point out one or two corrections. I did my PhD in Tanwas. After that, I joined college in Pukod, Kerala, and I'm assistant professor there itself, continuing. And during this lockdown period, I was very lucky enough, fortunate and enough to teleguide surgery, an open thorax surgery from sitting over Pukod, and do that in Malaysia, in Penang. It was just a 800 gram puppy, miniature pincher puppy, vascular ring anomaly. We could teleguide using our telemedia facilities. We could guide anesthesia and surgery both from college. And the surgeons the doctors over there, they acted as my hands to do the surgery. So starting from anesthesia, preparation, up to full recovery, we guided from Pukod. That was a memorable historical event that we all are very proud and happy, still cherishing that memory and a very professional achievement for our veterinary profession.
Thank you, sir. So it was a great experience for everybody of us, like what you did, sir. Like it's a great achievement for Indian counterpart of us. Like we are proud to have you with us. So like we'll start with the PPT. So and after the PPT, I'll give insight to all the participants. Like Dr. Anirudh will also be available with us. Is there for the discussion for all the question answer sections with Dr. Suryadas sir also. So I request Suryadas sir to please start the presentation, sir.
So very good afternoon, good evening to all. Before going into the session, first of all I thank the PPAK and the Natural Remedies for giving me an opportunity to talk to all of you around all over India and abroad. Once again thanking both PPAK and Natural Remedies. Let me start sharing.
Yes, sir.
Is it?
Sir, you have to go to action and to enable screen.
Yeah, under the actions there is no share screening. Screen sharing is not.
Just right, sir.
Share a media. Send
No,
a
sir,
call.
Okay. So Sorry, the storage is full. They're saying something.
Stage is
Just a minute. Just a minute, sir. I'll just check it, sir. There's no option coming over there.
Yeah, no
Okay.
option.
Just a minute, sir. Now you can do, sir.
Yes.
Please.
Has it come? Is it visible?
Not yet, sir. Just it's coming. Yes, sir.
I hope all you can see my slide.
Yes, sir. Yes, sir. We can see it, sir, properly. Sir.
Okay. Very good evening to all. Today's class is on tips to improve anesthesia in practice. So before going into the topic, I would brief what the outline of this presentation. This will cover the practical tips that will help you improve your anesthetic outcomes in clinical practice and thereby reduce the risk and complications. I will not be detailing about individual protocols for various types of patients. Instead, and also I would not be briefing or teaching you or presenting about the doses. This is all small tips that will help you improve your anesthetic practice and provide a good outcome. So to improve your anesthetic outcomes, the best is use safe anesthetic agents and follow safe anesthetic procedures. That is the only way that you can improve. That is the best way that you can improve the anesthetic practice. Use safe anesthetic agents and follow safe anesthetic procedures. But we should remember that there are no safe anesthetic agents and there are no safe anesthetic procedures. There are only safe anesthetists. That is, you are the only person that is safe. That is who perform the anesthesia. So we cannot depend on any safe anesthetic agent, or there are no safe anesthetic procedures. It is only you. So you have to know each and every patient as a separate individual, and each anesthetic event should be customized by you who is familiar with a wide range of anesthetic options. Thereby you can have a very good you can have a very safe anesthetic practice and good outcome, thereby reducing the risk of anesthesia. Okay. The first is you have to treat each patient as separate individual. Do not use the same protocol for all the patients. We might study one protocol from one place, and we do not take it for granted that the same can be used for all the patients. You can have a plan for patients undergoing routine surgeries like OHE, castration in young, healthy dogs and cats, and the elective procedures in healthy animals can be undertaken with the same protocol. But you remember that you have to adjust these protocols for patients that are older or ill, and for procedures that fall outside the routine, outside your routine practice. Okay, or also in complicating medical conditions like patients with liver, cardiac or renal disease. Do not use the same protocol for all the patients that comes to you for surgery. You have to tailor the anesthetic protocol or the doses and the combinations that will suit the other patients instead of using the same protocol that you use for your OHE and for the KLE in the sick animal also. Okay. Next is you have to know the breed, keep in mind the breed peculiarities. And see if there is, if you are not familiar with the breed, you refer and see if there is any specific peculiarity related to anesthesia with that specific breed. For example, I have shown you here the pug, the boxer, hound, chow chow, and these breeds pugs, they have a brachycephalic, they are brachycephalic, they have upper airway obstruction, so you should be very careful for such breeds, and they have a resting heart rate that is very low. Use of acethromycin, use of psilocin, all these drugs you should be cautious with such breeds. And boxer, they are very sensitive to psilocin. You should avoid using psilocin in boxers. You should avoid use. It doesn't mean that avoid means it's contraindicated. Always try to avoid, if at all, if you want to use psilocin or acethromycin. They are very much sensitive. So you should know that if you know that this complication is there, you will be prepared for that. So related to very lean and thin breeds like hounds, they have such breeds have they lack hepatic microsomal enzymes. They do not have body fat, so they will usage of anesthetic drugs in such breeds. The recovery will be very slow, and you have to use since there is not much body fat. The tiny doses would be enough to induce anesthesia in such breeds. And related to the fourth breed, see the tongue. You cannot use the tongue color to measure or assess ascertain the oxygenation status. Okay, so for each breed you have to plan. You have to have a separate plan. You have to plan your anesthesia. None of us we are all surgeons. Surgeons are always impatient. They doesn't have good patience. Since we want to do surgery, we are now becoming anesthetist also. Isn't it? That is the practice. We do the anesthesia and we concentrate wholly on the surgery. We will be planning for the surgery, but not for the anesthesia. So always plan for the anesthesia. Expect the unexpected and be prepared for that. Know the peculiarities with each particular breed of dogs, and accordingly you have to act. Okay. Next is we have to consider the temperament. Not all dogs will be of the same temperament. See, this dog is very quiet, calm, and lethargic. There will be some Labradors which are very aggressive or which are very active and alert. Hyperactive will be there. While some other Labradors will be very calm and quiet. You will be having a very cool. In such type of temperament, you have to always reduce the dose of the sedative drugs that you use. Consider this Saint Bernard. If I want to use psilocin in this dog, I will be using, instead of routine our psilocin, we use it at 1 milligram to 2 milligram per kg. Never use psilocin at 1 milligram per kg in a dog that is very cool, calm, and quiet, with a quiet and lethargic temperament. Try reducing the dose of the psilocin. So this dog may get sedated, would get sedated even at 0.1 or 0.2 milligram per kg of psilocin. Instead of using 1 milligram, you reduce the dose of the drug, sedation, pre-medicant sedative drug that you use in such type of animals, such type of dogs. See, this particular dog, he is very anxious. In such anxious breed, anxious animals, there will be release of catecholamines. You have to provide anxiolysis. Then the best drug for anxiolysis is azithromycin. So that anxious dogs has to be provided anxiolysis. Such dogs will be, see how aggressive or dangerous to handle. Such breeds of such type of dogs should should receive a heavy premedication with drugs that render them extremely sedate. That is, it should cause profound sedation or to the level of light anesthesia. Okay. And regarding to athletic dogs, the one cardinal point that we have to keep in mind is they have a resting heart rate which is very low. And this will be reflected in their heart rate during anesthesia. And that is normal. We need not treat it. Okay. So that is another point that we have to keep in mind. We have to know the resting heart rate. The resting heart rate, if it is low, we have think of using atropine. If it is high, you can avoid using anticholinergic. Okay. But in athletic dogs, they have the resting heart rate physiologically normal. Resting heart rate is low. You need not intervene in that. And the same thing will be, the low heart rate will be reflected in there during the period of anesthesia also. Okay. And routinely do a blood test that will help you assess the hemoglobin status. If the animal has low hemoglobin, the oxygen carrying capacity will be less, and that will be reflected even if they are provided 100% oxygen. The animal will not be getting enough of oxygen for the tissues. And that will the blood test will help you assess the liver and the renal functions. Apparently, the dog might be looking healthy, but when you do a blood test, you will come to know that the animal will be having a mild hepatic dysfunction or a mild renal dysfunction that would be reflected on the post-operative period. If you follow a same protocol that you use for other patients, you have to do some modifications. You have to do for renal patients, if the animal is having mild hepatic renal dysfunction, you have to think of giving pre-medicating with you have to induce mild diuresis, provide intravenous fluids that help clear the anesthetic drugs post-op. Okay, so that will, the routine blood test should be a routine before any surgery. Assess the body condition. See, you have to have an accurate body weight. See these two dogs, one is very obese and the other is of an ideal body weight. Before, see whether you have to see whether the dog that is presented to you is of an ideal body weight or not. Calculate, you have to calculate the drugs based on their ideal or lean body weight. The first dog that is around looking around 50 or 60 kg, you have to calculate it for around 30 kg. Yeah, because if you calculate for and also if you calculate for the actual body weight that is assessed, you will be overdosing the patient. And these obese dogs, they will not breathe well under anesthesia because these abdominal and thoracic fat increase, there will be increased workload for breathing, and this limit the compliance of the thorax. And the animal during anesthesia will be, you will notice that he will be spontaneously breathing. The rate of respiration will be 10 breaths per minute or 15 breaths per minute, but that doesn't mean that he is ventilating ideally. He will be hyperventilating. You have to assist ventilation in all obese dogs, irrespective whether they breathe or not, because they do not support their ventilation. Okay, so in animals that are obese presented for surgery, you have to have a person assisting the ventilation, even if he is breathing spontaneously. Okay. And if you calculate the dose based on the obese actual body weight, you will definitely overdose the patient. So this dog has to be, the doses should be calculated for its lean body weight. For this particular height and for this particular age, what should have been the ideal body weight? To that ideal body weight, we have to calculate the dose of the drug. So, example, if we are calculating psilocin, instead of taking 60 milligram, this animal should need only 30 milligram. But we will, to be on the safer side, it is better to reduce or avoid psilocin. Or if other drugs are not available, you reduce the dose of psilocin, and you will be able to achieve the same effect of same depth of sedation if you can combine psilocin with an opioid. So here, what I would prefer, if I do not have other better drugs available with me, I am left with only psilocin, I will reduce the dose of psilocin to 0.1 or 0.2 and combine butorphanol, an opioid that will provide sedation. So butorphanol I will combine at 0.2 milligram per kg body weight, not to 60 kg body weight. I will take it for 30 kg body weight. 0.2 into 30 plus 0.2 psilocin into 30. Combine in the same syringe, we can do sedation. And in such obese dogs, once they are sedated, they will have their respiration will get they will have a difficult respiration, and you have to provide oxygenation, mask oxygenation, pre-oxygenate them, so that you will get enough time for intubation and gaining access of airway and providing ventilation. Okay, so that should be a plan for such obese patients when it is presented for surgery. If possible, try to induce these dogs intravenous. Induction should be quick. If you gain access of airway first and provide the rest of the drugs later, that will be a better plan for such obese patients. If he is not allowing handling, if he is little aggressive or is not compliant, you can reduce the dose of sedative drugs by like psilocin, for example. You add with you can add opioid like butorphanol along with that. And once he is amenable to handling, then you can cannulate the vein and use propofol, a quick induction, and gain access of airway, and later do the rest of the drugs that are needed for you controlling pain, and your analgesic plans or protocols can be added later. Okay. If the animal is very thin, like this, you should calculate the drug doses based on the actual body weight. If he is 20 kg, 15 kg, calculate for 15 kg, not for the ideal body weight. Okay. They lack insulating fat and body gets colder very soon, and such dogs, they have to take care of not this dog also, for any animal, you have the body temperature, you should prevent hypothermia. These dogs, specifically these thin and lean dogs, will become very the body temperature will reduce quickly, and it has to be maintained. Also, neonates, infants, puppies, such animals, their body temperature should be maintained. Okay, and you should take extra care for these animals. And the dose calculation should be based on the actual body weight. What about if the animal is very cachectic? It reduces the dose of the anesthetic drugs. So to cite And these animals will be hypoproteinemic. You will definitely overdose the patient if you calculate with the normal dose. For example, almost all of the anesthetic induction drugs are protein bound. So protein binding will reduce the availability of the drug. These animals will be hypoproteinemic. If you give the anesthetic drug based on the normal your routine practice, more of the drug will be available in the blood because there is no protein or a very less number of protein to bind these drugs. What happens to all the drugs? That whatever that you give will pass the blood-brain barrier and cause anesthesia. So you will be overdosing such patients if you calculate the body, the anesthetic drugs based on the normal practice. So in such animals, you have to reduce the doses of the anesthetic drugs. Geriatric patients will, next is geriatric patient. These geriatric patients will definitely take it, consider that all geriatric patients the renal compromise. Should not deprive water in such patients. You can fast the animal owner not to deprive water. You have to ask them to feed water, give water at 1 hour, up to 1 hour or 1.5 hours before the surgery. The deprivation of water and the stress will cause, it will get, the renal status will get further compromised. And in such geriatric patients, it is always ideal, it's the best, the good practice is, ideal practice is to induce mild diuresis and start IV fluids prior to surgery. That will help renal clearance of the drugs, because almost all of the injectable drugs are cleared by through the kidney. And during anesthesia, most of the patients, these patients, in our routine practice that we practice now, generally most of us use not many anesthetic drugs. We'll be using in geriatric patient, since he is very sick or aged, we might not use, we will be using 1 or 2 drugs. And intraoperatively, there would happen hypotension. When there is hypotension, or if you suspect, if you anticipate there is hypotension, you should not use preemptive NSAID. There is a practice that is preemptive analgesia is providing analgesia of 1 hour before the surgery. At the event of hypotension, the first phenomenon that happens in the body is renal vascular. The blood vessels will constrict in the kidney to preserve the body fluid. The renal vessels will get constricted. So their perfusion will be reduced. And after the surgery, and at this event, if you had given NSAID, that will aggravate the condition of the kidney, and post-operatively these patients will be presented back as with the renal complaints. Okay, and avoid high concentration of inhalant in such patients, in geriatric patients. How we can avoid high concentration of inhalants? You have to have a balanced anesthetic plan. Analgesic plan should be adopted, whereby you can reduce the inhalants. Why? The purpose of reducing the inhalants is, in almost all of the induction anesthetic drugs, the side effects are dose dependent. So if you are able to reduce the dose of the induction and maintenance drug, the side effect, which is the side effect? Hypotension is the major side effect. When this hypotension can be reduced, what is the advantage of reducing the hypotension? When you reduce hypotension, if the hypotension happens, there will be renal vascular constriction. The perfusion will be reduced, and that will be reflected on the postoperative period. That is why in geriatric patients, it is always ideal, do not not to deprive water, provide water just few hours before the surgery, until few hours before the surgery, induce mild diuresis, and start fluids prior to the surgery. And if you have any doubt that your patient might not maintain BP intraoperatively, consider that most of your patients may not be maintaining good BP. So in geriatric patients, avoid preemptive meloxicam. Avoid if you are using inhalant anesthetic agents like isoflurane, sevoflurane, you try to reduce the concentration. To maintain anesthesia, use minimum concentration. If you want to maintain the anesthesia in minimum concentration, you have to have a continuous rate infusion of the analgesics and sedative or other drugs that we call it as sometimes CRIs, or we call it as partial intravenous anesthesia, that will support analgesia, pain management. If the pain is controlled, you can reduce the inhalant agents. If not all of us will be practicing inhalant anesthesia. So what about the others who do the surgery with the injectable drugs? You try to reduce the dose of the injectable drugs. How we can reduce to cite an example, I can cite with the propofol. So when a geriatric patient, we will use propofol. High dose of propofol will reduce the BP. That will have compromise on the renal functions. Reduce the propofol by giving additional supportive drugs like ketamine intravenous at analgesic dose. That will help reduce the dose of injectable agents used for maintenance. Okay. And if your patient is young, do not fast overnight. Check when it is presented, check the glucose levels, and if it is low, provide glucose if needed before the surgery. That is an ideal practice to improve your anesthetic outcomes in young patients. Okay, and protect their body temperature. That is very important. Protect their body temperature. Okay. In old, young, sick, or compromised patient, you pre-oxygenate them using a mask for 5 to 10 minutes. When you pre-oxygenate these patients, the blood will be saturated with oxygen. There will be a reserve, and the chances of desaturating and becoming hypoxic will be reduced. So if you are not pre-oxygenating with a mask, you are not pre-oxygenating. And if you imagine that if you take little more time for intubation, gaining access of the airway, whatever that oxygen that the patient will become hypoxic. And if that could be avoided if you pre-oxygenate these patients, young animals, old animals, sick and compromised patient. Okay. So except for adult healthy animals, others, ideal, you pre-oxygenate them. And that will give you enough space for breathing space, your playing space, gap for you to intubate. And by the time you will not get desaturated. Okay. Always use an IV cannula. Secure it with use IV cannula and maintain IV fluids. So we may consider that sometimes we may take it for my castration, maybe 10 minutes or less than 5 minutes I can do castration. But if at all, if there is an emergency, if we want to do some additional drugs, or happens if your surgery lasts long, another maintenance can be done only if the IV, the cannula is patent. So you have to have an IV cannula always, and that will be it will be a very good practice to improve your anesthetic outcomes. Okay. If you anticipate difficult intubation post induction, as I told you earlier, these breeds, brachycephalic breeds, they especially brachycephalic breeds, you have to pre-oxygenate them always. Okay. Next comes the use of syringes. Will be very rarely, or we may not be operating Shiva or like this small always. Our routine practice will be dealing with the dogs from 20 kg up to 40 kg, like 50 kg. But and one fine morning, or very rarely, you will be presented with small dogs. When such animals, patients are presented, you should always use smaller syringes. Cite an example with psilocin. See, psilocin, taking 1 milligram of psilocin in a 2 ml syringe is very difficult. You have to have half of the division, 1 milligram. Point in 1 milligram is one division will be 0.1 ml, that will be 2 milligram psilocin. Okay, so taking smaller quantities of the drugs, always use insulin syringes or 1 ml syringes with 100 divisions. That will be a very ideal, and you will never overdose the patient, and it will be very easy for you to do the calculation. And do not hesitate to calculate using a pen and paper. Every one of us will not be might not be a very good may not be possible. We cannot do mathematics in our mind. Mind calculation will be difficult. So use a pen and paper, and use smaller the patient, use smaller syringes. So when you take psilocin 0.1 mg, that is you need to take 1 milligram. You in insulin syringes, how many divisions you need? You need that is 0.1 ml. 1 milligram means 0.05 ml, that is 2.5 divisions. When you take 2.5 divisions, then extend that drug using distilled water and mix it and give intramuscular or intravenous as the case warrants. Okay, so extend the, if the volume of the drug is small, don't inject that acid. You extend it, so the distribution volume will be high, and that is a more ideal practice than using the small division that you had taken in the syringe. Okay. Then next is always see to which class your patient belongs. As I told in the beginning, not all patients are same. So you have to know whether is of ASA1, ASA2, 3, 4 like that system, it is having any systemic illness. If it's an emergency, is very terminally ill, accordingly you have to have your anesthetic plan. As I told, you should not use the same anesthetic protocol for all the patients. Okay. And please, you should not use drugs per volumes. That is a practice that we had developed. Most of us, our friends, my friends, they not the youngsters, maybe many of us will use anesthetic drugs. You give 1 ml, 0.5 ml, use always in milligrams, and do not rely on your memory for the doses. The reason, 25 years ago, when we studied, there were only a couple of drugs, 1 or 2 few drugs, very few drugs. And there was no balanced anesthetic practice. We used the 1 or 2 drugs that we had, psilocin and ketamine, or thiopentone. There was no propofol. So at present, there is a wide range of drugs and practice of balanced anesthesia, practice of CRI, and remembering all the doses. It's very good if you remember all, but still I advise, do not rely on your memory. If once you do, see how many drugs are available now, ACP, the availability, presentation, the 10 milligram per ml, dose ranges, it is literally, it is good. As an undergraduate student, we assess the students' anesthetic knowledge based on the doses that they remember. but that time is gone. It is gone. We remembering the dose doesn't mean that we know anesthesia. You forget about the doses. Don't rely on it. But you should remember this is something around this much range. Keep it in your mind, but don't rely on it. You depend on the chart that is pasted on your theater. As and when you use it daily, that will get memorized in your mind. And use these drugs instead of relying on the memory. Okay, that will be a good practice to follow, rather than I appreciate all that can remember all the doses. But as and when we add on more and more of the drugs and use various combinations, some drugs we might forget. And when you calculate CRI for some drugs, CRI, dexmedetomidine CRI is 1 to 3 microgram per kg per, whether it is minute or hour, I forgot. So there are some at CRIs per kg, per minute, there are per kg, per hour. Sometimes we may get confused. Okay, so it's always better to have a chart pasted that with the standard drug doses and use that, or have it in your mobile. Okay, next. Control nociception via multimodal analgesic approach. That is the practice, the latest practice that we abroad, and we are also stepping into this practice of multimodal analgesia. What is multimodal analgesia? Instead of giving one drug, or instead of blocking the pain using meloxicam alone, pain pathway is not through cyclooxygenase pathway alone. There are various other pathways. If you can block each of those pathways with individual drugs, that is multimodal approach. Okay, so you can use local blocks, you can use opioids, you can use meloxicam or NSAIDs. So using multiple drugs, that NSAID act in cyclooxygenase pathway, opioids act in there at opioid mu, kappa, delta receptors. Then local anesthetics acts at the conduction level. So if you employ all of these drugs together, that is multimodal analysis. If that will enhance, that will improve their anesthetic outcomes, you will be practicing a better practice anesthesia than using single drug alone. Okay, and follow balanced anesthesia. Balanced anesthesia means use of small amounts of several drugs, anesthetic drugs. What is anesthesia? Anesthesia is a triad. Is unconsciousness, muscle relaxation, analgesia. So use unconsciousness, you can use one drug, employ a drug for unconsciousness. Sedation, muscle relaxation, you can use muscle relaxant drugs. And analgesia, as I told, there are a number of pathways. So that is multimodal balanced anesthesia. Small amount of several drugs that act in specific sites to achieve the triad, analgesia, unconsciousness, and muscle relaxation. So that particular balanced approach will improve our anesthetic practice, rather using one drug alone or two drugs alone to achieve everything. We will be using at higher doses if you use very few drugs, one or two drugs. Okay, for example, psilocin and ketamine. When we use psilocin, most of us practice psilocin use and psilocin and ketamine and diazepam. Psilocin analgesia lasts for maximum 20 minutes. So by the time when we start our surgery, prepare the animal, cannulate and drape the patient and start the surgery, the analgesic action of psilocin had vanished. And we will be giving midazolam and or benzodiazepine and ketamine for induction and maintenance. So is benzodiazepine an analgesic? No, it doesn't provide analgesia. Does ketamine provide analgesia? Yes, ketamine alone provide analgesia there. So when does it provide visceral analgesia? No, it will not provide visceral analgesia. So when we start open the abdomen and start manipulating the abdominal organs, animal will show some signs. Those are visceral pain. And we mistake that animal is becoming light. Anesthesia is becoming light. What we will do, we will push in more of the injectable drug, that is mistaking that is light anesthesia. We increase the dose of the drug, push the animal deeper into anesthesia, giving more and more of the induction drug. So that is not balanced. So instead of that, you use multiple drugs for muscle and visceral pain. Control that. What is visceral pain? You control visceral pain. You control ketamine provides only somatic analgesia. So understand your drug well, and accordingly, you if you act, use of multiple drugs in small quantities and use of several drugs that target the triads. That will be a better practice for anesthesia than using few drugs. Okay. This is to cite some example. It is little complicated. You can, on the left hand side, you see the anesthetic state, the anti-nociception, that is analgesia. Animal is not. How that state can be achieved? Exclusively these drugs, that is ketamine, fentanyl, dexmedetomidine, lignocaine, NSAIDs, they exclusively do anti-nociception. While implicit maintenance indirectly propofol, isoflurane, sevoflurane, our injectable or maintenance drugs, they reduce the ability to perceive pain and thereby contribute indirectly to anti-nociception. While you see the next state, unconsciousness, propofol, the same drugs, but indirectly this ketamine, the drugs which I mentioned earlier, ketamine, fentanyl, dexmedetomidine, they indirectly help unconsciousness. How they contribute to unconsciousness by arresting the nociceptive induced arousal. Imagine that you are sleeping. Someone comes and prick you with a pin. You are into deep sleep. Someone is pricking with a pin. That prick of the pin or the induction of pain that is sensed by you will be sensing that, and that will increase your chances of arousal. If imagine that you have taken an excellent analgesic like morphine or fentanyl and you are sleeping, you will not feel pain. And this anti-nociception, this nociceptive induced arousal can be prevented by these drugs. Immobility, that is relaxation. Exclusively the NMBS, that is neuromuscular blocking agents like a tracurium, they provide immobility, while indirectly our propofol, isoflurane, they contribute to muscle relaxation by blocking neurons at level of the spinal cord. This is just an example how this multimodal general anesthesia is practiced. Okay. So, as a take-home message, we should keep in mind, remember that, or by heart, that nociceptive pathways have strong connections with the arousal pathways. Hence, administering anti-nociceptive agents, that means, what is nociception? Nociception is sensation to pain. In an anesthetized animal, does he sense pain? Yes, nociception will be there. If there is pain, animal is sensing, the nociception happens, there will be increase in the respiration and increase in the heart rate. So this administration of anti-nociceptive agents, they will help decrease arousal, thereby decrease the requirement of the agents needed to keep the patient anesthetized, and thereby reduce the dose dependent risk associated with those drugs. So that is the best practice that we can follow in our routine practice. Okay. And next, employ local nerve blocks. Local nerve blocks, before any painful procedure, they prevent full activation of the pain pathway, and thereby the total needs of the analgesic and anesthetic drugs can be decreased. And most of us, even me, I also believe animal is anesthetized, fully unconscious. Then why should I use a local? Why should I use a local nerve block? When I do a laparotomy, when I do an OHE, and I am anesthetizing the animal. And what benefit is there if I use? Can't I do it without a local infiltration? If you do that local infiltration, animal will not sense the pain induced by the incision. Thereby, if the animal is not, the nociception is controlled. Reduce the side effects. Okay, and these local nerve blocks doesn't cause any central nervous depression, organ depression, and they will help animal recover very quickly. Okay, so always, as far as possible, try to use local nerve blocks in your anesthetic plan. Why it is not this is not routine? Because many of the local nerve blocks need skill. We are not that much expertise in doing, except for some few of the nerve blocks. We are not very good. Most of us, we are not very good epidural or maintaining an epidural catheter. We might not be experienced using a nerve block, brachial plexus block. If in case I have to cite an example for an amputation of the limb, forelimb, if I want to amputate at the shoulder level, forelimb amputation, imagine that I am using an local nerve block, brachial plexus block. How much anesthetic will I need more? No, I can finish the surgery with the block itself, not with the block alone. Okay, that is what is meant in this particular slide. Next, do not stress your patient. That is another point that every one of us should keep in mind. Don't stress your patient. Sedate whenever required. If you feel the animal is not cooperating, do not forcefully restrain such patients and prepare them for surgery, because situations become more risky. There will be cardiac compromise. It is better to sedate. It is safe and better and ideal to sedate them and do the preparation. Okay, you either tranquilize or sedate or anesthetize them and prepare. Okay, not manually restrain and prepare the patient. And if you do such a practice, sedate them whenever required. If the animal is very cooperative, not have much stress with, owner can hold the animal quietly on the table. Okay, otherwise try to sedate them. Or that is an ideal practice that will increase your outcome of anesthesia by reducing the doses required for induction and also for the doses for maintenance. Okay, and there will be very less cardiac and respiratory depression. Okay, because if we do not sedate these animals, the doses that needed for induction and maintenance will be high, and accordingly will be the cardiac and the respiratory depression. I hope the point is clear. And sedation will smoothen the recovery process after the surgery. Okay. And I told you always, whenever possible, you have to sedate. But say such patients who do not sedate, never sedate them. Instead, you have to induce them quickly and gain control of airway. Never try to sedate these type of patients. They will have the situation will become, you will be put in creating a sorry figure. These ones, if these animals are sedated, such animals, obese and brachycephalic, they will have upper airway restriction, the brachycephalic airway syndrome will be aggravated. And you will note that these patients, after sedation, you will see the tongue becoming blue. It is getting compromised. It becoming hypoxic and hyperventilating, and you will not be able to intubate at that time and provide oxygen. So in such patients, provide a mask pre-oxygenation. If the animal is he may not tolerate mask. So you can instead you can put a plastic cover, use and over the head and provide oxygen into that. It will be less stressful to that patient. And while pre-oxygenating, you can induce them quickly and gain control of the airway instead of sedating. So avoid sedation in such animals. So after sedation, you will get the patient the sedation will be varied. Some patients will be looking like profound sedation will be there. Some as below, the one as below, that is not that sedated. So depending on the sedation, depth of sedation post after your pre-medicant sedative drug that you use, then you have to decide your induction dose. Okay. For example, generally propofol, we take it the induction 4 to 4 milligram per kg. Okay, maybe many of us might be taking it 6 milligram per kg or 5 milligram per kg. So for a 25 kg dog, that will need 100 to 125 milligram. That means around 10 to 12.5 ml of the propofol. We are used to big syringes. When, see, for the first patient, if such deeply sedated dogs, never take propofol or the induction drug as that we used to do routinely. Instead, these such profoundly sedated dogs can be induced with as low as 0.5 to 1 milligram per kg of the propofol. So if you take 0.5, see how much low a volume is needed. Just 1.25 ml is needed. Imagine 10 ml and 1.25 ml. You take 1.25 ml in a 2 ml syringe, extend it with the distilled water and inject, use for induction. By extending that small volume, you still you can reduce the dose of while injecting. If you are taking only 1.25 ml this length, your finger is trained to give a 10 ml syringe injection with a 10 ml syringe. You will be injecting it quickly, and you will be injecting the entire 1.25 ml into the patient. If you extend it with the distilled water and take that 1.25 ml to the 3 ml volume, and while injecting, you will notice that halfway or 3/4 way or maybe less than that, you will see that patient is completely induced. Thereby, this is how you can reduce the induction dose. Use depending on the sedation, the depth of sedation that had achieved, then choose your induction dose. And the induction dose will be so small. If it is small, extend it with using distilled water. Then mix it and give it with the usual speed, because your fingers are trained, memorized. They have a memory of injecting it at one particular speed. So if you use that small volume, then you will be pushing the entire thing inside, and the animal will be profoundly overdosed. Okay. and induce with injectable drugs. Those having inhalant practice, always it is ideal induce with injectable drugs IV route, because when you use intravenous injection for induction, you can titrate. That means, as I told in the previous slide, when you inject halfway, you can see the patient is down. When you open the mouth, it is relaxed. The eyeball has gone down. Okay, I can stop the. If you imagine that you use it for intramuscular, then you will take the entire volume and give the full dose intramuscular. And that we cannot titrate there. Don't use inhalants, because that is mask induction. Especially in unsedated animals, it will cause struggling, release of the adrenaline, and it is risky to the patient. Okay, so always the best is induced intravenous, not with intramuscular or not with inhalants. Okay. And how can I inject it? How fast I should do it? You should not provide it too fast, not too slow. What happens when you give it too fast? There is the chances of apnea will be more. What happens if you give too slow? Animal will get excited. That is another issue. Okay, especially when you use propofol, animal will be very much sedated on the table. If you novice practitioners, they inject it very slowly. When I started my PG work was in anesthesia in 98-2000. I used propofol. That was the first time or second time. Not many are used to propofol. Propofol was being launched at that time. When I used propofol at that time, my induction dose was around 10 to 11 milligram per kg. The reason was I was giving it too slow. My patients were getting excited. So when you give too slow, you will give a large volume. And when you divide the dose with the body weight, you will see that it is very high. So you have to inject it in not that fast or not too slow. So it inject over 60 seconds. Now the induction dose of propofol is, for me, is as low as 0.5 milligram to 1 milligram per kg. So that you will memorize, you will train your fingers will get memorized, trained how to give the injection. So we cannot teach you this fast you give or this slow you give. That will be, you can gain in practice. Okay, slowly you will come to understand that this much fast it will not cause. If it is too high, that will cause apnea. Okay. So next is, after injection, you have to wait for the effect before giving the next dose. You have to remember, go back to your pharmacology, the volume of distribution. Administer saline bolus for distributing the drug into the system. Imagine that you are using psilocin. Imagine we are using psilocin. So, after alpha-2 agonist, the circulation will be less. When you use the injectable agents, that will not get distributed into the brain very quickly. And when you use and when you inject, you will notice that there is a delay in the onset of action. So if you do not wait for the effect to happen, we will mistake that, oh, the drug that I had given has not taken effect. What I will do, I will take the next another volume or another milligram per kg and give further. And what happens after that? The additive effect of both the drugs, the high dose will give profound side effects. Okay, so you wait, then before giving the next dose, wait, see the effect, then proceed. If the volume is small, what is the best practice? Extend it. If it is small, after giving into the cephalic vein, You take another syringe with saline, push it. That should be pushed into the body, or take a larger volume. That should be the ideal practice. These are very, very small tips from these that will improve our anesthetic outcome. Okay, I know that many of us are waiting for. Most of us need protocols. I'm very sorry. You should forgive me, bear with me, not providing you, teaching you protocols. Okay, protocols. I don't want you to provide you fish. Instead, I am trying to teach you how to catch the fish. I hope everyone will bear with me for not teaching you doses and protocols. Okay, just tips to improve the practice that you are doing, or that you are going to do in the future. And intubate the patient and secure the airway. It is we don't think that it is the procedure might not take long time. So why should I intubate? No, intubate always. It is ideal. Intubate the patient. Gain control of the airway. Use an endotracheal tube. That will increase. If you start observing patients after induction with and without intubation, those with intubation, their oxygenation status will be in a better plane than those without. When you intubate, you can provide oxygen. In case there is any mishappenings, that you can bag the patient, okay, and inflate the cuff, and that will prevent aspiration of the contents that gets regurgitated during the maybe saliva may get accumulated in the oropharynx. It may go inside. So always secure the airway, intubate and secure the airway. Okay. And there is another very common mistake that we do following induction-induced apnea. So I told you in the beginning, what happens when you do too fast? Animal will stop its respiration. What happens when the animal, you see the apnea? Oh my God, you will get panicked, isn't it? What happens when you get panicked? You will immediately take an ambu bag and start pressing. You will be aggressively ventilating the patient. Okay, that is one mistake that we do. We will aggressively ventilate the patient. So when you bag aggressively, why the apnea happened? Apnea had happened because of the fast injection of the drug and high dose of the drug. Okay, so when apnea happens and you start aggressively bagging, the alveoli get stretched, and the receptors on the alveoli will send a feedback to the brain telling stop respiration. A negative feedback during this normal spontaneous respiration. When you take a full breath, the alveoli get stretched, and that alveoli with the receptors will send a negative feedback to the brain, and brain will stop. So when you aggressively bag, you will be continuously sending the negative feedback to the brain, and the animal will not come back to spontaneous respiration soon. And when you aggressively bag, you prevent the cardiac return, venous return, the blood getting returned into the filling the chambers. So two ways you are compromising, you are adding more injury to the patient. Okay, don't get panicked. If you want to bag, ventilate to the optimum that is needed. How much optimum is needed? You know how much breath my chest will expand. Accordingly, for each patient, there is a maximum level. Accordingly to that level, you ventilate or you bag the patient. Don't use the same bag, the 2 liter bag for all the patients. Maybe your dog will be around 5 kg. It will need only 5 into 10 50 to 100 ml of the tidal volume, and you will be pushing the 2 liters into the the small lung. Use small ambu bags for such situations. Okay, so those who are using inhalant anesthetics, when after apnea, during apnea, there will not be uptake of the inhalant anesthetic agent into the body. Only when there is respiration, ventilation, the inhalants go into the lung. Okay, and I told in the beginning, the surgeons are not patient enough. We all are not very impatient. We will start immediately. We will start doing the surgery. While inducing, the animal will suddenly wake up. So the premature wake up will be there. Then what you will do? Hey, the animal is getting up. What is doing? You inject little more of the drug. Again, we will inject little more of the drug, and animal will go in again into the apnea. Okay, so this is a very common mistake that will happen. You should avoid that. You have to gently bag, and you have to increase the uptake of the inhalant into the body, and meanwhile the apnea that it had happened, the drug that has gone into the brain, it will redistribute and it will come back to spontaneous respiration. Okay, and do not use the same bag size for all your patients. Those having inhalant anesthetic practice, you change the anesthetic bag, reservoir bag. Like those who use ambu bag, have different sizes of ambu bags with you for with different patients. Okay, how we can take the reservoir bag size? It is, you multiply the body weight with 60. If the animal is 20 kg, 20 into 60, it is 1.2 to 1200 ml, 1.2 liter. If you have a 1.5 liter bag, take that, or you can take a 2 liter bag, likewise. Okay. And always monitor your patient during anesthesia and recovery. That is very important. We are, again, to repeat, we are not anesthetists. We are only surgeons. All of us are surgeons. So once the animal is anesthetized, okay, we will start our surgery. Most of us may not even turn and look into what is happening with the patient. So it always ideal practice monitoring 5 to 10 minutes. If you want to perform well, you need not need a monitor always. You are the best monitor in the world. Everything else is that assist your observation about your patient. So those who do not have a monitor, don't feel dejected. Those who do not have an inhalant machine, don't feel dejected. Injectable drugs can be used for anesthesia maintenance also, but we should know the best practice. Thereby you can reduce the risk and increase your outcome. Okay, so monitor the patient every 5 to 10 minutes. Monitoring and simultaneously performing surgery will reduce your efficiency as a surgeon. If you want to practice, be a very good surgeon, you should have a very good anesthetist. Even a poor surgeon also need a very good anesthetist, because for the surgeon to perform the best, he should get a very good anesthetist. The person who take care of the anesthesia, the surgeon need not bother that side. You will take care of the anesthesia. Imagine that I am a very novice surgeon. I may take a surgery, castration for 1.5 hours. I need a good anesthetist to take care of the anesthesia. So then only poor surgeon like me taking 1.5 hours can perform the castration very good, excellently. Likewise, for me to do a open thorax surgery, I need a person like me to perform the anesthesia and monitor the patient. So always monitor the patient during anesthesia and recovery. It is very essential. Okay, monitor oxygenation. Very simple. We have SpO2 monitors. These are small tongue probes costing less than 2,000 rupees that can be used in our routine practice. Okay. If we do not have this oxygenation, these monitor devices, you just look at the tongue color, memorize this color, and changes in the color of this will tell you that the animal is not having proper oxygenation. So monitoring, physical monitoring is very important. Do not depend entirely on gadgets. You train your skills. Your skills. The surgeon, he can see the operative field and tell, that is not properly ventilated or oxygenated. That color of the blood will be changing. So likewise, you either use your monitor or these devices, proper oxygen, monitor oxygenation, monitor circulation. Circulation is monitored by monitoring the BP. Animal should be, the BP should be, MAP should be above 80. Okay, so if you do not have that facility, just see the color of the mucous membrane gums. You can press the gums, see the CRT, that is less than 2 seconds. Okay, very good circulation. That is how physical method of monitoring. If you note that there is some doubt is there, you can depend on your and see the monitor device and see whether what you have seen is right or wrong. So your physical method of monitoring is very, very important. You are the best monitor. Okay. Monitor ventilation. As I told you earlier, the animal will be spontaneously breathing. So it is ideally ventilating. No, never. He may be having the rate of respiration will be okay, 10, 12. But if the tidal volume will be very small, so that will not ventilate, provide ventilation. So how can we monitor ventilation? The gold standard, the ideal way is measuring the EtCO2 and tidal carbon dioxide level. That should be between 35 to 45. If you do not have the EtCO2, how we can just monitor the movement of the thorax or movement of the reservoir bag? If it is not ideally ventilating, what we can do? Just provide optimum bagging whenever needed. That is the ideal practice. You practice that. Don't consider patients spontaneously breathing. All patients are ventilating ideally. Provide breaths. That will improve your anesthetic outcome. That is the best way to, best practice of anesthesia than putting the patient, he's having normal rate 10 breaths per minute. Need not interfere. No, you monitor the ventilation and provide ventilation bags as and when needed. Okay. Now you have to monitor the cardiac functioning through ECG. And next is majority of the induction and maintenance agent does not provide ideal analgesia. Propofol, diazepam, isoflurane, sevoflurane, none of them provide good analgesia. Ketamine will provide. Okay, so you have to recognize intraoperative pain and control nociception. How can we identify the intraoperative pain? When we are doing the spaying, putting the skin incision, fine, animal, there is no response. Open the abdomen, we search pulled the uterus, the uterine horn. Animal is moving like this. Animal is becoming light. No, it is not light anesthesia. It is animal is sensing pain. So you have to identify nociception, intraoperative, and control that. You can improve your anesthetic outcomes and practice. That is ideal. So intraoperative pain is always mistaken as anesthesia getting light, and we do not. We increase in the respiratory rate, increase in the heart rate. That means it is sensing pain. So your analgesic plan is not ideal. Remember that side effects, instead of managing nociception, we by mistake provide incremental induction and maintenance drugs or increase the inhalant concentration. What happens with that? When you increase the, you push the more and more of the induction agents, that the patient will be, your side effects will be increased because dose dependent. Side effects are dose dependent. Another is extremely sick patient. What we will use, propofol is the best drug. We use propofol alone or propofol with inhalant. Yeah, because both are safe. Propofol doesn't accumulate in the body, inhalant doesn't accumulate in the body. No, never use such thoughts, because neither of them provide analgesia. Hence, we will be using higher dose of propofol and inhalant for induction and maintenance, and thereby higher will be the dose dependent side effects. Okay, so instead use a balanced multimodal anesthetic approach with CRI, continuous rate infusion, and nerve block that will help reduce the propofol and inhalants, and hence they will reduce the dose dependent side effects. Use a multimodal approach, as I mentioned in the previous slide in the beginning. How, if you have a very good analgesic plan, you need the requirement of propofol and inhalant, it can be reduced. Propofol high dose will reduce the BP. High dose of inhalant will reduce the BP. When there is fall in the BP, hypertension, what happens? This extremely sick patient, in other words, he is very sick. When there is hypotension, the renal perfusion will reduce, and post-operatively they will come back to us as a renal compromise. Their creatinine values will be increased. So in such patients, avoid using meloxicam, avoid using high doses of practice of propofol alone or propofol plus inhalant alone. Use multimodal approach, use local anesthesia, thereby you can reduce all these drugs doses, and thereby the dose dependent side effects. Avoid routine pre-medication with atropine in geriatrics, because geriatrics, almost most of our geriatric animals, they will have one or somehow their cardiac compromise will be there. It is just asking our grandfather to run a 100-meter race. Making him run a 100-meter race, you are making the geriatric heart to beat more number of times using atropine. You avoid using. You should not use atropine in such animals. Instead, if at all it is needed, you use glycopyrrolate. Okay, and if you use dexmedetomidine, you avoid anticholinergics with the dexmedetomidine. Whenever alpha-2 agonists are used, we are seeing alpha-2 agonists, after use of alpha-2 agonists, there will be fall of the heart rate, isn't it? Bradycardia will be there, reduction in the heart rate. Why it reduces? Because there is alpha-2 agonist, we call it as, there is hypertension happens there. Hypertension, the peripheral vascular, there will be vasoconstriction. Vasoconstriction happens, that is to increase the flow of the blood to the vital organs. BP increases. So against constricted peripheral vessels, we make the heart to beat more against these narrow peripheral vessels. The workload of the heart will be more. Okay, so to avoid that, atropine causes more of the increase in heart rate, and that is not, it is detrimental in geriatrics. Avoid using atropine. And they also avoid using anticholinergics in dexmedetomidine. You should, those who do not have proper monitoring, unable to monitor BP and heart rate, but use that or glycopyrrolate. Otherwise, I do not use atropine or glycopyrrolate routinely. If it is needed, if the heart rate comes below 40 or 60, then I use. Otherwise, no. Okay, so those I cannot advise. Avoid total avoidance of use of atropine. It is better avoid atropine in geriatrics and avoid in dexmedetomidine. Okay, but for others who do not do not practice stringent monitoring, use atropine when with the psilocin. Okay. And next is, we should be very vigilant with recovery, and monitoring should, you should monitor during recovery also. Else we will have to say surgery was successful, but the patient died. This happens. We will be the patient. We will perform the surgery. Surgery went out well, and we all were very happy with the surgery. And with that happiness, we forgot by monitoring of the patient during recovery. So during recovery, and it may die. So surgery went off well, successful, but the patient died. So you have to be very vigilant during monitoring, vigilant and monitor during recovery. And while extubating, do not deflate the cuff completely. If the cuff is deflated, completely, the saliva and the regurgitated whatever material that accumulates anterior to it will, when you deflate completely, that might go into the trachea once you extubate. So that you have to half deflate it. Once the animal starts swallowing reflex, gently pull so that whatever material that is accumulated will come into the pharynx and the animal will swallow. Don't completely deflate. If you anticipate that there might have happened some regurgitation, saliva was there, salivation was there, you turn the head down, little tilt it down, deflate it, half deflate, pull it, then swab the oropharynx with a long artery forceps with a swab, clear the airway. That is the way that you have to practice so for a better outcome. Otherwise, we will have to say, sorry, the surgery was successful, but the patient died. Okay. Next, so with this, before ending the presentation, I would like to provide a take-home message. Many of us still use few drugs systemically in patients. Very few drugs we practice. We do not practice, but I am not blaming everyone. Many of us practice multimodal, but majority of us, we are not that very familiar with the multimodal. Use of multiple drugs. Imagine meloxicam, then bit of opioid, then ACP. Likewise, once after the surgery we count, there will be 8 or 10 drugs. So if you use systemically in patients, use small amounts of various sedatives, analgesics, general anesthetics, and employ local blocks, that will produce stable anesthesia with less side effects, morbidity, and mortality. And thereby, that practice of these small tips will help you reduce the risk and increase your anesthetic outcomes in your clinical practice. So I know that everyone will not be happy going home without any take-home messages. So that the best take-home message that I have kept it in the last 2-3 slides. How can I calculate for a CRA, continuous rate? I have been telling about various continuous rate infusion that will help anesthetic outcomes. So there I have a few examples that you can practice in your routine practice. There is a multiplying factor. This makes things easy for you. To cite an example, midazolam. Midazolam is available 1 milligram per ml, and the CRA is, I have taken it as 3 microgram per kg per minute. To get a CRA for 2.5 hours duration, how much of the midazolam you have to add? You just multiply the body weight with 0.45. If it is 20 kg, okay, multiply by 0.45 and you will get the volume, provided it is 1 milligram per ml. If it is 5 milligram per ml and you will need to have 3 microgram per kg per minute, you multiply it by 0.09, that much volume. Or if you want to take it as milligram, you have to multiply by 0.45. Okay. So with this, there are various other drugs, lignocaine, ketamine. Lignocaine we use at 20 to 80. So for our routine practice, we can take it as 50 microgram per kg per minute. Ketamine 40 microgram. You can combine these drugs in a single 100 ml infusion and put a CRI, and that will provide, the plasma level can be sustained can be maintained throughout the surgery. Thereby, it will avoid use of, this can avoid use of intermittent bolus. Many of the soft tissue surgeries that are not that much painful can be maintained by a protocol using this. Okay, multiply the body weight with the factor for each drug to obtain the milligram. If you want to obtain the milligram of lignocaine, you multiply by 7.5 and add it to 100 ml infusion, and or use pediatric infusion set, that is 1 ml equals 60 drops, and administer at 40 ml per hour, that is 40 drops per, you can count it. You need not, those who are having a CRI pump, infusion pump, CRI syringe pump or an infusion pump, it is easy. But for those who do not have inhalant machines, those who do not have CRI machines, it is a very easy way that we can practice. You count for any patients above 5 kg for up to large breeds, you can put the drops as 40 drops per minute or 10 drops per 15 seconds, and it will maintain CRI for 2.5 hours. So many of the surgeries last 2 hours or little above preparation, induction, then after draping, and average. Many soft tissue surgeries other than spaying and castration, it may last for around 2 to 2.4 hours. For that, I had calculated, I had prepared a practical way for those who do not have inhalant machines, for those who want to have practice a multimodal approach. I will cite an example with for 20 kg body weight, CRI for 20 kg body weight, midazolam, lignocaine, ketamine, fentanyl. Fentanyl has become available. Those who do not have fentanyl, you can even combine ketamine, lignocaine, and midazolam. Midazolam, if you want opioid or butorphanol is there, butorphanol also can be added. As a CRI analgesic protocol, this would be one that I would like to suggest. So during surgery, if you see that there is visceral pain, you can give a small tiny dose of dexmedetomidine or psilocin. Very tiny dose. If it is ketamine is being used in the CRI, the somatic analgesia will be there. When there is a visceral pain, you can give a very tiny dose of the dexmedetomidine or psilocin. If it is psilocin, I will use 0.1 or 0.05 or 0.025 milligram per kg when I feel that there is a visceral pain. I will prepare that 0.05 means 0.05 into 20. That will become 1 milligram, isn't it? 0.05 into 10 means 0.5 into 2 means 0.5, 1 milligram. 1 milligram I will take in an insulin syringe. That will, 1 milligram will be half of 0.1. 0.1 ml will be 2 milligram, half of it. I extend it and I will give slow IV half of it. So that will control the visceral pain. So in between, I will, instead of using psilocin continuous rate infusion, visceral pain is there, I will suggest you to give that as intermittent when needed and use this as a continuous rate infusion that will manage the analgesia. That is, midazolam will provide muscle relaxation, lignocaine will provide systemic analgesia, ketamine will provide somatic analgesia, fentanyl will provide analgesia through the opioid pathways. So for example, 20 kg body weight, you can multiply the midazolam with that is multiplication factor for calculating volume of the drug. That is, you take 1 milligram per ml of midazolam and 3 microgram per kg per minute. You multiply 20 with 0.45, you will need 9 ml of the midazolam, 9 ml, lignocaine 7.5 ml. So when you add 9 plus 5, then 14, 14 plus 21, 21, 23, 23.9. 23.9 ml of saline we have to withdraw and discard and add this combination and use the pediatric infusion set to at 40 ml per hour. That is 40 drops per minute or 10 drops per 15 seconds. Put it as CRI. Okay, so after your induction, you will be inducing with psilocin pre-medication. Then after that, you will induce with sedation with psilocin. Then after that, you will use midazolam and ketamine. After midazolam and ketamine, midazolam 0.2 and ketamine 5 milligram per kg IV. After induction, you have to give fentanyl 5 microgram per kg IV. That is a loading dose. Ketamine we already used. Lignocaine you have to use 2 milligram per kg IV loading dose. Midazolam we already used. So that will act as a loading. So then you use this as continuous rate infusion. That will have a better, that is, we call this as balanced anesthesia, multimodal balanced anesthesia. This will last for 2.5 hours, your surgery period. In between, when you feel there is a recovery or pain, you can use little dose of psilocin or dexmedetomidine. If you have not used dexmedetomidine, you have to use a loading dose of dexmedetomidine. This is a take-home message that I would like to give. And 1 hour, 30 minutes is not enough. I know that this is not enough to teach anesthesia. All nuances, everything about anesthesia, protocols in various patients. And one more small take-home message, that very easy to calculate. If you want to put lignocaine CRI for 100 ml infusion with those drugs, that presentation is milligram per ml. And ketamine is available as 50 milligram per ml. This calculation cannot be taken for the drugs like fentanyl that comes in microgram per ml. Fentanyl is presented as, it is available as 50 microgram per ml. You cannot use those drugs for this calculation. Those drugs that are available in milligram per ml, if you want to put a CRI, individual CRI, not combination. Okay, as I told in the previous slide. Ketamine, example 50 milligram per ml. If you want the 40 microgram per kg per minute, not per hour, per minute, body weight, example 20 kg. You just multiply the body weight with 6. Whatever be the body weight, multiply by 6. So ketamine, 120 milligram you have to take, 2.4 ml you have to take. Withdraw 2.4 ml from saline and add 2.4. Mix it and administer at 40 ml per hour for 40 microgram per kg. Lignocaine, if you want 50 microgram per kg per minute, you administer at 50 ml per hour. It will provide 50 microgram per kg per minute. Okay. So if you want lignocaine at 20 microgram per kg per minute, you administer at 20 ml per hour. How much milligram you have to take? You have to take 20 body weight into 20 milligram. Okay. So this is another take-home message, the easy calculation for those who do not have the injectable infusion or infusion syringe pumps or infusion pumps. I hope and there is this small article that will help you understand more about multimodal balanced anesthesia. And with this, I come to the conclusion, end of the presentation. Thank you so much for the patient hearing for 1.5 hours and more. I was provided 1 hour. I'm sorry that I took little more time.
Dear sir,
In fact,
thank
we
you
are
very much,
very
Dr.
thank you for
Surya
you
Das sir,
completing all the slides.
assistant professor in Pukod Veterinary College.
Thank you.
I think you should be prepared to receive so many calls or text messages for so many clarifications now onwards, because this was a very clear and really useful presentation, sir. Very crystal clear, and none of the slides were crowded. We are all really able to follow, and your flow of presentation was really excellent, sir. We are so happy to have you here for today's lecture. I think on behalf of PPAK and all of our office bearers, I am so happy to thank you for spending your precious time and be here with us today for this great presentation and most useful presentation. Thank you very much, sir. I request Dr. Nagesh Reddy to go ahead with questions.
Thank you.
Yeah, we can go with the questions, Prakash.
Yes, sir. Yes, sir. Sir, so what we have did, like, just summarize some questions because there are a lot of questions being asked, and like, so we tried to summarize and differentiate some questions. So what we, I'll just read out the questions to you. So most of the
I have
questions
lost the
what we
connections for temporarily. I think I can read out. The first man, Gaurav Raika, is asking
Yes,
about
sir.
equine anesthesia. If you feel relevant, you can answer, sir. Otherwise, because this is the Small Animal Practitioner Association,
So
you can
very
ask.
sorry, I am not the expert in equine.
Yes. Okay. I will go to the next question.
It's
How much time approximately take place for induction by propofol?
the propofol, it is one arm to brain circulation time. That's if the animal is profoundly sedated after silencing, that circulation will be delayed, and that might, in such patients there might be a delay. Also it depends on how quick you induce, how quick you inject the drug into the body, how quick it gets circulated from the injection site to the brain. On an average, an arm to brain circulation time. That varies in different patients. If the blood circulation is, cardiac output is low, that will take little more time. That is why I told wait for the effect, then give the next step. So we cannot hard and fast we can tell this much 60 seconds it will take, or it might take 90 seconds. It varies with patients.
The next question is by Nikhil. Nikhil is asking.
I just like to add on one point. I think thiopental sodium also is almost the same effect like propofol, where it has a one-arm brain circulation. Am I right, sir? Or?
Yes.
Yes. Okay, sir. The next question is by Nikhil. He is asking about capnography for monitoring.
Yeah. What is the doubt?
He is asking about use of capnography to monitor anesthesia.
Yes, it is capnograph is used to monitor ventilation. To know whether if we want to know whether the patient is ventilating ideally or not, capnography is the best. With the citing some examples, we might see the SpO2 100. We are giving 100% oxygen. Your monitor will show 100% or 98% or 99% or 100% SpO2. But the patient may not be ventilating ideally. The carbon dioxide that accumulated in the alveoli might be high. Only if there is proper exchange of fresh gas with the alveoli, that means that is ventilation. That can be monitored only using a capnograph.
Okay, sir.
Yes, sir.
Sir, I'll proceed with the
question
other
is
questions,
about how to make the recovery faster post-surgery, post-anesthesia. How to make the patient recover faster is asked by Ishwar.
If you are using inhalant anesthetic drugs, inhalation anesthesia.
It is not very specific whether it is IV or inhalant.
For IV, you have to depend on the liver and the kidney, the metabolism and excretion. The recovery depends on the metabolism and excretion in the liver and the kidney. If it is inhalant anesthesia, the recovery can be made faster by turning off the vaporizer and increasing the fresh gas flow, emptying the reservoir bag, and providing 100% oxygen. That will make, and providing manual breaths, again emptying the reservoir bag. That way you can increase the enhance the recovery. For injectable drugs, we cannot enhance the recovery if we are using injectable drugs. If you can use intravenous fluids, we can use diuretics. Thereby, the excretion can be the excretion can be enhanced.
So, adding to one point, so when you're reducing the anesthesia, say you're using an inhalant anesthesia, do you do it in stages or do you reduce all of a sudden? Say you are using it 2, the concentration, do you reduce it to 1 and then do it to 0, or do you want your animal to recover very fast? Because it's also a problem. Am I right?
See, if we are using a non-rebreathing circuit, that is an open, that there is no rebreathing. There, if you switch it off to 0 in one step, the recovery will be very fast.
Okay.
Recovery will be very fast.
We'll go to the next question.
Yeah. Next is.
Parameshwar sir, I have just summarized the question. I'll take in that flow. That will do.
Yeah, okay, you can go ahead, Prakash.
Yeah, we'll go to the next question, sir. Deepak knows about observation outcome of EtCO2 graph peaks. EtCO2, E2 carbon dioxide graph peaks.
Yeah, you have to maintain between 35 to 45, and that capnography alone, this time is not enough. I cannot explain that in a very short period. That itself need another 1-2 hours of presentation. Graphics means the capnographs, how to interpret the capnographs.
And Manish is asking whether intubation is useful or not when we use intravenous anesthesia.
Please, can you repeat?
Yes, sir. Manish wants to know intubation is useful or not when we use intravenous anesthesia.
Always intubation is useful.
Yes, sir.
Intravenous or inhalant. That will gain the airway control, and you can provide oxygenation, improve the oxygenation than without doing it.
Yes, sir. One more very interesting question, most useful also. What to do when the animal show convulsions while induction done with xylazine ketamine combination?
Xylazine ketamine combination, when we is it whether they is used together?
Together, yeah. He wants to know together.
Yeah, xylazine and ketamine mixed in a single syringe and given together. When you mix the xylazine and ketamine and give together intramuscular or intravenous, it will induce anesthesia quickly. But when you use intramuscular, the effect of the ketamine acts first. So the animal shows not convulsions; it is the cataleptic state. The cataleptic state. It is that is the ketamine that acts first, then the xylazine later. So the other way would have been better.
He wants to know what to do, because many times we have also observed, the freshers, beginners, and people who are not very much familiar with anesthesia and all become panic. When they have the owner standing in front of other side of the table, they become more panic. So if suddenly catalepsy is, what to do? That's what his question is.
So it is better. It is what my advice is: avoid that.
Yes.
How we can avoid that? You sedate the dog first. Then once it is sedated, then induce with the ketamine midazolam. There will not be any convulsions.
Yes. Next question is by Abhishek. What is the better alternative for atropine that you have already mentioned, sir? It is glycopyrrolate, correct, sir? Alternative? Yes, sir.
Alternative means in geriatrics, glycopyrrolate is preferred than atropine. There are only these two drugs available for practice: atropine and glycopyrrolate.
Yes, sir. The next question is about in a geriatric patient having metastasis or having metastasis, pulmonary metastasis, let us see. Pulmonary metastasis, for a short procedure like CT scanning, what is the anesthesia that you advise, or only propofol is useful?
No, propofol, you have to, I would suggest an opioid if he is terminally ill, sick, an opioid will butorphanol. Butorphanol will, along with a benzodiazepine, that will provide enough and good sedation.
Done, sir.
Okay, sir.
Butorphanol. Audible, sir?
Yes.
Yes, sir. The next question, we'll go to the next question by Akshaya. Is about anesthetic protocol in emergency cases.
Yeah, emergency cases.
Yes.
And on the emergency cases, as I told earlier, the combination of an opioid with the benzodiazepine will help. You can achieve equal depth of sedation there with the normal protocol. So sick patients and emergency critical patients, an opioid with a benzodiazepine will be a very good choice for induction or profound sedation.
Dr. Nanjundappa, VCare Pet Clinic, wants to know about Zolatil from Virbac Company.
Zolatil, I have not, till now I have not experienced Zolatil. I am also waiting for it. But to some little knowledge that I have, it is diletamine solazepam.
Yes.
So the same thing is what we use, ketamine, midazolam. Something of the same.
Yes, sir. So about company, let us not talk about. And Abhishek wants to know the volume of inhalant anesthetic in general. Volume of inhalant anesthetic in general.
Oh, that means it is not
Right.
very particular.
No problem, sir. So I
Yes,
will take
sir.
some.
We'll go to
some other
Abhirami's
specific
question.
questions, sir.
Kindly explain regarding the bagging procedure and when it need to be done and how it should be done. Bagging.
Yeah. When we are using local anesthesia, the bagging can be done. If the patient should be ventilated, the peak inspiratory pressure should not go beyond 25 centimeters of water. That is ideal. I do not know whether she has the pressure monitor in the machine, whether her question is pertinent with the ambu bag. If she is using ambu bag, you can have a pressure monitor that is attached to the ambu bag that will detect the airway pressure. It is 25 centimeters of water. If those who do not have that pressure monitor, the ideal way of bagging is bag to the optimum exertion of the thorax. What is that optimum? That you have to memorize, you have to know with each patient. This much, okay, this much is good for this small patient. This much, grade 10. This much, a small patient. That I can only show with my with my hand. Okay, so it is optimum. What is that optimum? The optimum is 25 centimeters of water. How frequent you have to ventilate, provide breaths, that is 5 to 10 breaths per minute. That's all.
Thank you, sir. Sir, so there is another question also being asked. You can hear me, sir, properly?
Yes.
Yeah. So we have some summarized few questions over there. So in that, like we found some questions are asking regarding the combination of anesthesia. So one question is regarding what is the best anesthetic protocol for pregnant females in normal and fatty conditions?
For pregnant, as I told in the first slide, there is no best anesthetic practice. But still, the best is that you have to tailor it. If the animal is very exhausted, it depends on the patient. If the animal is, the mother is very exhausted, the patient, the fetuses are alive. Exhausted means the fetus also will be exhausted. The heart rate will be low. So in such animals, it will be ideal to give atropine, because atropine crosses the placental barrier and increase the rate of heart rate, and the output of the heart is dependent in neonates, in small puppies. The output is dependent on the rate. So in such exhausted animals, exhausted or the terminally exhausted puppies or the mother, you can give what you call atropine. Okay, then you can use lignocaine, local anesthetic line block. Local anesthetic line block. You can pre-medicate 1 milligram per kg or 2 milligram per